So, very good evening to all. Hope you're all doing good. And we were like covering very important topics for the past 3 days. And mostly we are discussing about the hepatobiliary system. Then we just moved on towards the next important thing that is going to be your renal system. So, in the last class, we covered renal stones. Then in the subsequent class, I covered urethral injury and bladder injury. And today we are going to see another important essay that is going to be your renal mass. So why I termed it as renal mass? Anyone, can you just tell me? Because renal mass is going to be a wholesome chapter. So don't read it as a renal cell carcinoma, oncocytoma. Everything is going to be like a together. So what we are going to read actually is we are going to just see everything in a together manner. So we're going to start with all the renal masses. So whichever going to present as a mass. So we are going to compare all the renal tumors and read it together. So we're not going to read it separately. We are going to see all the tumors together and we are going to discuss it today. So before that, I'll just add two important things. One is going to be the yesterday's session. So yesterday we discussed the urethral injury and bladder injury, right? So I will be like posting another video shortly by today or tomorrow. I'll just put it in the YouTube. So the old video, I'll just made it private and new video will be posted. So in that, I'll be adding new updates. So I have covered everything, but there are many topics that are yet to be covered in that same video. So I don't want to make it a separate video and at the end of the day, before your exam, I don't want you to go through both the videos. Instead, I'll make it as a single video and upload it in the YouTube. So the thanks to be said to Dr. Sendil sir, sir, renowned surgeon and Speed Medical Coaching Center Institute director. And he was the one who actually told me the things that are needed to be added. So I'm very grateful to him. Today I just attended his classes and I could just find many new important things that are needed to be added into the existing video. So I'll make it as a fresh video and give you all. Okay. With that note, good evening, everyone. So let's start with the today's discussion that is going to be your renal mass. Now, can you tell me whether the patient comes to you with symptoms for renal mass, let it be a benign or malignant? So is it a symptomatic finding or is it an incidental finding? Can you tell me? Renal mass, be it a benign or malignant. So most probably when we are finding the renal masses in 90% of cases, whether it is going to be benign one or whether it's going to be an incidental one or whether it's going to be a symptomatic patient who comes to us. Can you tell me? Can you tell me, guys? Let me see who is going to answer this. Remember, I just want you all to write it down. Renal mass பொறுத்த வரைக்கும் 90% the people is going to come with a normal without any, I'm telling about benign tumors, everything. I'm going to talk as a whole renal mass. So renal mass as such, I'm not talking about renal carcinoma specifically, but renal mass, it is going to be incidental finding. Most of the time, your renal mass will be incidentally found in the mastoral checkup in the ultrasound. Okay, va? So now this ultrasound which we have done, that is going to tell us that there is a renal mass. Renal mass nepa solvengappa. So ungaloda kidney size increased irukku. So there is some cystic lesions or there is a solid lesions. So we are going to classify the entire renal mass into two. Either it is going to be a cystic mass or it is going to be a solid mass. Either it is going to be a cystic mass or either it is going to be a solid mass. Clear? So now we have cystic mass and in the other side, we have something called as solid mass. Now what I am going to do is, remember, when I wanted to find a cystic mass or whenever I find that there is some cyst present in the kidney, now I have to classify it. I have to classify it. How I am going to classify it? I am going to do the next step. What is my next step which I am going to perform? So I'm going to now first what I'm going to do, I'm going to I'm going to classify the entire cyst into based on something called as Bosniak classification. So what I'm going to do is when I find a cystic lesion, okay, in my patient by doing an ultrasound examination, the next immediate step, what I'm going to do is I'm going to classify my lesion. Now, my classification I'm going to perform, I'll write it separately, guys. So write it down separately, put a heading as Bosniak classification. So this is expected when the question is asked on renal cyst. So I want you all to write it down. I want you all to write it down. So this is called as Bose-Nayak classification. What is that? You have actually 4 classes in that. Okay, 1, 2, then you're going to have 3, and then you're going to have 4. What is class 1? Class 1 is nothing but a simple cyst. So how can I call a cyst a simple cyst? Can anyone tell me in the chat box? When the ultrasound features which we are going to find, when it is going to be anechoic, when they are going to have a imperturbable wall. If there is going to be a round one, then you are going to call it as a simple cyst. In a simple cyst, what you have to do? Can you tell me what will be your next step when the patient is going to be diagnosed with a simple cyst? When the patient is diagnosed with a simple cyst, what will be your next step? Whether you have to do some workup, whether you have to do some next investigation. Can you tell me? Do you need to do some investigation? According to Bose-Nayak classification, you need not do any investigation. There is no workup needed because this patient will have a 0% malignancy. So here the patient is also not going to have any symptom. So therefore, you are not going to do anything. This is about your simple cyst. Now, second one is minimally complex cyst. Minimally complex cyst. So what will you do when the patient, you're going to have a minimally complex cyst, or how I am going to term it as minimally complex cyst, just based on what? Just based on the features. Just based on the features. How we are going to tell? When it is going to have a single, when it is going to have a thin septation, when there is going to be a single thin septation, and there is going to be a thin calcification, thin calcification. So that is going to be your minimally complex. Remember, even in minimally complex, there is going to be no workup done. Why I am not going to perform any workup? Because again, this is going to have a 0% malignancy. There is 0% malignancy risk. So I am not going to do unless there is any symptoms. So patient is also not going to have any symptom. So why I am bothered? I am going to just do a follow-up. Just I am going to ask the patient to come after 6 months maybe to take a USG. Okay, that's all. So, but now coming to the third one. Before moving to the third one, there is something called as 2F. What is this 2F? Minimally complex, but they require follow-up. Okay, minimally complex, but they require follow-up. That is called as your 2F. When do you classify it as a 2F? Again, when it is going to be having a thin septum. So septations are going to be thin, but here the calcification is thicker. So here what happened? The calcification is thicker. So septation is thin, but calcification is thicker. Therefore, you are going to go for a CT scan. You're going to go for the next one. What is the next one? CT scan. But remember, this as a 0. This is going to have a 4% annual malignancy risk factor. Malignancy risk factor is 4%. CT scan irukku. So since CT scan is there, you're going to do that. And you're going to recommend the patient for annual follow-up. You're going to recommend the patient for annual follow-up. This is about the 2F. Next is going to be your 3. What is stage 3? Stage 3 means you're going to call it as indeterminate. You're going to call it as indeterminate. What is indeterminate? So thick or multiple septation and mural nodule. What is that? Thick and multiple septation. Thick and multiple septation. Along with that, you're going to have a mural nodule. Along that, you're going to have your mural nodule. So this is going to be the features of indeterminate. So if the patient is going to have a indeterminate classification, indeterminate type of features in your ultrasound examination, what is going to be the next step? Next step is partial nephrectomy. What you're going to perform, guys? You're going to perform partial nephrectomy. Partial nephrectomy. Okay. In partial nephrectomy, what is the percentage of malignancy? Remember, in partial nephrectomy, that is going to be in the indeterminate, the percentage of malignancy is 50%. Now, can you get the logic? Now, can you get the logic why you do partial nephrectomy? See, guys, one thing what I learned from my PG preparation is, okay, these things, this table வந்து பாத்தீங்கன்னா சில faculties or maybe சில online platforms or what they are doing is, so why do you need all these 50%, 4%, 0%? Let it cut off. So like that they will be doing. But the ultimate thing what I learned, that too at this late stage before my exam, and I'm going to go for a revision, that time I am now understanding that all these values are going to tell you something in the table. 0% malignancy, அதனால தான் நீங்க ஃபாலோ பண்ண மாட்டேங்கிறீங்க. 4% malignancy. So அவ்வளோ malignancy ரிஸ்க் இல்ல. பட் நீங்க சிடி எடுத்து ஆனுவல் ஃபாலோ அப் பண்றீங்க. 50% malignancy chance இருக்கு. ஆனா why do you want to leave the patient? So what you're going to do is you're going to do a partial nephrectomy. Okay, each value in the table, whichever given in your Bayesian law, communicates something. So try to understand that. And coming to the fourth one, what is the fourth stage? Clearly malignant. So it is clearly malignant. Since you're going to call it as clearly malignant, what I'm going to see in my ultrasound? In ultrasound, I'm going to have a solid mass. In ultrasound, I'm not going to have a cystic mass. Here, I'm going to have a solid mass, but I'm going to have a cystic spaces. Cystic spaces. So in this case, you're going to see whether this is 100% malignancy. So what you're going to do, you're going to stage your renal cell cancer. So it's clearly malignant. So renal cell cancer தான் இருக்கு பேஷண்ட்டுக்கு. So you're going to clearly, you're going to do a staging of renal cell cancer. And what you're going to do, you're going to either perform a partial nephrectomy or total nephrectomy, depending upon the case. Depending upon the case. Clear up. So this is about your Bose-Naik classification. Now, you know what you're going to perform in your cystic. So this is ultimately going to be your cystic state. So cysticல நம்ம என்ன பண்றோம் அப்படிங்கறத நான் சொல்லிட்டேன் உங்களுக்கு. Next, if it is going to be a solid tumor. If it is going to be a solid tumor, next what you're going to do. Now, if it is a cystic tumor, I told you what you're performing. Okay. So if it is going to be a solid tumor, what you will be doing? So let's see. If it is going to be a solid tumor, you're going to directly go for a CT scan. You don't have any classification and all. You're going to directly go for a CT scan. In CT scan, you're going to see two things. In CT scan, what are the two things you're going to see? One, so just write it down along with me. One, you're going to see whether my patient is going to have any central stellate scar appearance. Central stellate scar appearance with spoke wheel pattern. With spoke wheel pattern. Spoke wheel pattern. Okay, central stellate scar appearance with a spoke wheel pattern. If I'm going to have a central scar appearance with a spoke wheel pattern, then the answer is going to be renal oncocytoma. Oncocytoma. So the answer is going to be renal oncocytoma. Second thing is going to be if you have a negative enhancement. If you're going to have a negative enhancement. If you're going to have negative enhancement, then it is going to be angiolipoma. Angiomyolipoma. Okay, angiomyolipoma. Third thing, if I'm going to have more than 15 HFU, then it is going to be your renal cell carcinoma. So now I understood the three things what I'm going to understand from the solid tumor. So solid tumors in the kidney, it can either be renal oncocytoma or it can be angiomyolipoma. Or it is going to be renal cell carcinoma. மூணுல ஏதோ ஒன்று தான் இருக்க முடியும். ஒன்று renal oncocytoma, அப்படி இல்லைன்னா angiomyolipoma, இல்லைன்னா renal cell carcinoma. But what we will do, even I did the same thing when I was in the final year. So I will be reading renal oncocytoma separately. I'll be memorizing all the points in that. Then angiomyolipoma, all the points. Then renal cell carcinoma separately as essay. But ultimately, the patient is not going to come and tell you that the patient is going to have a renal cell carcinoma, treat me. Or the patient is not going to tell you angiomyolipoma, treat me. You are the responsible person who have to find what is the problem with the patient. For that, what you're going to do? Renal mass, usually it will be incidental finding. You're going to suspect a USG. So USG, if it is a cystic lesion, then you're going to classify Bose-Naik classification and you're going to treat accordingly. If it is going to be a solid tumor, you're going to see whether it is having a central stellate scar with spoke wheel pattern. Okay, by doing a CT scan. Or you will go for a negative enhancement. If you're going to do a negative enhancement, then it is going to be, if you're going to have a negative enhancement, then it is going to be a angiomyolipoma. If it is going to be having more than 15 HFU, then it is going to be renal cell carcinoma. So renal cell carcinoma. Now can you tell me what is HFU in CT scan? Can you tell me what is HFU in CT scan? It is nothing but it is a unit, guys. Okay, it's actually a unit. That's all. Okay, HNF is nothing but it is actually a unit. So when it is going to be more than 15, so when it is going to be more than 15, it is going to tell you about the radio density. So it is going to tell you about the radio density, and that is going to be identified in the CT scan. So it is a Hounsfield scale named after Sir Godfrey Hounsfield. He is the okay. He is going on this name only. This is a dimensionless unit universally used in the computer tomography to express the CT number. So CT number, it is going to give you how much dense it is. Clear? So this is all about your thing. So now basics all clear. So now tell me. Now your pay. Now what you have? So you have this one. So 1 minute. Okay, now what happened? Now you are going to have take a fresh page. Now you are going to have a solid on USG. You have taken a CT scan. It was a renal oncocytoma. Renal oncocytoma. And on other side, you can have a angiomyolipoma. Angiomyolipoma, when it is going to have a negative enhancement. Negative enhancement. Can you tell me from where you are going to have this angiomyolipoma? The name itself tells you. Myolipoma. What does it tell? It is arising from the angio is also there. Angio means blood vessel. So this is going to be a benign tumor. Remember, this is going to be a benign tumor that involves your blood vessel, that involves your muscle, that involves your fat. This is going to be arising from the perivascular epithelioid cell. It is going to be arising from perivascular epithelioid cell. Epithelioid cell. Okay, so this is going to be arising from epithelioid cell. This can be either a sporadic or familial, but more common one the sporadic lesion more than familial. Can you tell me what is the associated one important thing in angiomyolipoma? It is associated with tuberous sclerosis. This is associated with tuberous sclerosis. Tuberous sclerosis. Tuberous sclerosis. So what are the other features you see in the tuberous sclerosis? This is how you have to learn. So now I have told you about tuberous sclerosis. Can you tell me what are the other features you see in tuberous sclerosis? Can you tell me in the chat box? What are the other lesions you find in tuberous sclerosis? Very good. You see ash leaf macules. You see shagreen patches. You see adenoma sebaceum. Okay, all these are going to be other features that you see in the tuberous sclerosis. Usually the patient will be asymptomatic, as I already told you. And there is very, very rarely they are going to cause massive peritoneal hemorrhage. If this angiomyolipoma causes a massive peritoneal hemorrhage, massive retroperitoneal hemorrhage, peritoneal hemorrhage, rarely. This is going to lead to what? It's going to lead to Wunderlich. Wunderlich. It's going to lead to Wunderlich. Okay, va? So what is going to be the Lenz triad? What is the meaning of Lenz triad? So whenever you're going to have massive retroperitoneal hemorrhage, so you will have something called as Lenz triad. So this is a Lenz triad. What is Lenz triad? So what are the other things? You're going to have a mass, you're going to have a shock, then you're going to have a flank pain. Mass, shock, flank pain. Okay. So what will be your investigation of choice? Investigation of choice is CECT. இது வரைக்கும் எல்லாருக்கும் தெரியும். Now, how you are going to treat this patient? Treatment is very, very easy. Okay. So what is going to be your management in this case? We are going to see whether it is less than 4 centimeter. We are going to see whether it is more than 4 centimeter. If it is less than 4 centimeter, just go for observation. If it is going to be more than 4 centimeter, you are going to do thrombotic embolization. First thrombotic embolization பண்றீங்க. Okay, எதுக்காக bleeding stop பண்றதுக்காக. அதுக்கப்புறமா you are going to followed by partial nephrectomy. Followed by partial nephrectomy. Okay, now when it is going to be bleeding, what you will do in bleeding, we will go for a angio. We are going to go for angioembolization. So அதான் நான் இங்க சொல்லுங்க thrombotic embolization or angioembolization is going to be performed and followed by partial nephrectomy is given. Now a recent update from pharmacology for angiomyolipoma. What is going to be the drug you can give? Drug you can give everolimus. Everolimus is a recent drug that is approved for giving in angiomyolipoma. Okay, and what happens in your in some entrance exam, what they will do is they will give you the CT image. Okay, so in CT image, what you're going to find? So you can just open your textbook and also see. I'm not having picture, but I'll tell you how to identify. So you first identify your kidney. Okay, retroperitoneal organ, kidney. And the kidney la vandu pathina, if this is going to be your kidney, if this is going to have your kidney looks like, okay, what happens is inside your kidney you are going to have a blackish appearance. Inside your kidney you have some blackish appearance like this. So this is going to be your angiomyolipoma, black area. Yen black ah irukku because anga fat irukum, fat accumulation. So you are going to have your angiomyolipoma. Clear, right? So this is all about your angiomyolipoma. Hope you are all clear. Next, we are going to move into the renal oncocytoma. Rumba easy. Renal oncocytoma or patient kirunda. So what you are going to actually do? Oncocytoma is a benign tumor. And I want to ask you one thing. What is the cells which are present on your tumor cells are there, right? Where are they? Where are they rich in? Remember, they are rich in mitochondria. They are rich in mitochondria. That is a very important thing. So they are rich in mitochondria. Okay. So, and another important thing is they are going to be cytokeratin negative. This cytokeratin negative, why it is important? Because cytokeratin negative, this is going to help us in differentiating your, so it is going to help in differentiating from chromophobe type of renal cell carcinoma, Okay, wow. So this is another important thing. And can you tell me one syndrome where you have oncocytoma? Can you think and tell me from one syndrome, a genetic syndrome, where you are going to have your familial syndrome, where you will have a oncocytoma. So similar to the previous one, here also sporadic more than your familial. But in familial, you have one thing, one syndrome that is called as, anyone? Burt-Og-Dubase syndrome. Burt-Og-Dubase syndrome. Burt-Og-Dubase syndrome. Okay, why this is going to be a mutation at the chromosome number 17. So what are the syndrome now or multiple symptoms? What are the multiple symptoms you have, multiple disease you have? So one is going to be your oncocytoma. And I told you a differential diagnosis for oncocytoma in the previous point, right? That is going to be a chromophobe RCC. Chromophobe RCC. So in the syndrome, your chromophobe RCC and your oncocytoma together, they are going to be present. So that is the important thing. And the C is going to be your fibrofolliculomas. Fibrofolliculomas. Okay. And number D is going to be trichodiscomas. Trichodiscomas. Clear? So this is all about your thing. And now coming towards the histological pattern which you are going to have. Here you are going to have what? Here in this entire, I am talking about oncocytoma. Okay, histopathology, it is going to be like a large eosinophilic cells. So there is going to be a large eosinophilic cells. Why eosinophilic cell? This is because of the abundance of mitochondria, which is going to be arranged like a nest. So mitochondria arranged like a nest, and you're going to have large eosinophilic cells. Clear? So clinical features, again, it's going to be asymptomatic. And investigation of choice is going to be CECT. And can you tell me what do you find in CECT of oncocytoma? I told you already. It is central stellate scar. Central stellate scar with a spoke wheel pattern. Romba important, the terminology. Central stellate scar. So exam lo or essay lo or short note le enna pa எதிர்பார்க்க போறாங்க? உங்களுக்கு features தெரியணும். Clinical features தெரியணும். இதோட காஸ் என்னன்னு தெரியணும், ஹிஸ்டோபெத்தாலஜி என்னன்னு தெரியணும், ஒரு சிஇசிடியில் என்ன பார்க்குறீங்கன்னு தெரியணும், ஃபைனலி ட்ரீட்மெண்ட் என்ன பண்ணுறீங்க, அவ்வளோதான் அவங்க உங்ககிட்ட இருந்து எதிர்பார்க்கறது. ஸோ இன்வெஸ்டிகேஷன் ஆஃப் சாய்ஸ் சிஇசிடி. Now coming to observation. So what you're going to manage, how you're going to manage, then you're going to observe and wait. If the size increases, you're going to just wait. You're going to see if the size increases, then you're going to go for a partial nephrectomy. Now a question. See, from today onwards, what I will do is I'll also try to tell you other points that are related to this point. For example, if I CECT la inga central stellate scar appearance paakren sonenga. Central stellate scar appearance. Central stellate scar appearance வேற எங்கேயாவது நீங்க படிச்ச ஞாபகம் இருக்கா? Central stellate scar appearance. Can you tell me somewhere else haven't you read it? So வேற ஒரு கண்டிஷன்ல இதே மாதிரி சிடி பண்றப்ப நம்ம ஸ்டெல்லேட் ஸ்கார் அப்பியரன்ஸ் பார்ப்போம். எங்கெல்லாம்? ஒன்னு ஆல்ரெடி யூ நோ oncocytoma. The second thing is going to be your you're going to have your nodular hyperplasia of your liver. Focal nodular hyperplasia of liver. Third one is going to be your chromophobe RCC. RCC. That is going to be your thing. Now tell me this oncocytoma, whether they are going to be Bosnia classification பார்த்தோம்ல அதுல எத்தனாவது Bosnia classification இது வரும். So we have Bosnia classification 1, 2, 3, 4, right? Can you tell me in what Bosnia classification does this oncocytoma comes? So what is the Bosnia classification? What is the Bosnia classification? Type. Bosniak type என்னன்னு சொல்ல முடியுமா? What is the Bosniak type? This one oncocytoma is? It is going to be type 3 Bosniak. Write it down. So this is going to be a type 3 Bosniak. Clear, right? So with this, we have completed all the benign tumors. Now we are going to move into the malignant tumors. Malignant tumors, first and foremost, what we are going to see? We are going to see renal cell carcinoma. Okay. So your examiners are very, very smart. They can ask you not by just putting it as renal cell carcinoma. Renal cell carcinoma கேட்டா நீங்களா ஆன்சர் எழுதிடுவீங்க எஸ்ஏ. ஓகே ஆர் ஷார்ட் நோட்ஸ். அதுக்கு பதிலா அவங்க என்னன்னு சொல்லுவாங்கன்னா they will tell it as Gravid's tumor. Gravid's tumor. Or they can call it as a hypernephroma. Hypernephroma. So remember 85% of your renal neoplasm consists of renal cell carcinoma. Male la varuma female la varuma most common. Renal cell carcinoma male or female? Just attempt in the chat box, guys. Whether it is a male or in female, it is most common. Your renal cell carcinoma. Renal cell carcinoma occurs most commonly in male. Renal cell carcinoma occurs most commonly in the 0 to 7th decade. Okay. And what are the risk factors? Risk factors are going to be hypertension, tobacco intake, diabetic mellitus, thorax exposure. So this is the one thing I want you all to write it down. Thorax exposure. Then you're going to have smoking, obesity, and history of some drugs. What are the drugs that are going to cause renal cell carcinoma? Diuretics. So there is a increased chance of renal cell carcinoma in diuretics. You have your phenacetin. So phenacetin. So that is also going to cause a chance of renal cell carcinoma. So you're going to have different types of renal cell carcinoma. Clear? Are you all with me? So renal cell carcinoma different types இருக்கு. So first type, most common type is going to be your clear cell carcinoma. Clear cell carcinoma is going to be the most common. Okay. And renal clear cell carcinoma is there. Second, you're going to have a papillary carcinoma. Papillary carcinoma. And third is going to be your chromophobe type of carcinoma. Chromophobe type of carcinoma. And fourth is going to be your collecting duct carcinoma. Collecting duct carcinoma. Fifth one is going to be your XP11 translocation. XP11 translocation. And sixth one is very important. So this is the MCQ question. Most common type of renal cell carcinoma in sickle cell anemia. In sickle cell anemia. Can you tell me? Can you guess what is the most common cause of sickle cell anemia? The sickle cell anemia is the most common cause of renal cell carcinoma. So I'll see. I'll wait if someone answers. Let's see. So let me start with your clear cell carcinoma. Clear cell carcinoma, it is going to be due to deletion of 3p, 8p. So 3p, 8p. So both are going to be the reason for clear cell, and it is associated with von Hippel-Lindau syndrome and tuberous sclerosis. Tuberous sclerosis. இங்கேயே நின்று நம்ம இன்னொரு கொஸ்டின் பார்க்க போறோம். வான் Hippel-Lindau syndrome பார்த்தோம்ல, அதுல என்னென்ன டியூமர்ஸ்லாம் வரும்? ஒன்னு வந்து கிளியர் செல் கார்சினோமா, அது தவிர வேற என்னெல்லாம் வரும்? Anyone? Can you recall and tell me? Remember, von Hippel-Lindau syndrome, there is going to be a chances of pheochromocytoma, neuroendocrine tumor, and retinoblastoma, hemangioblastoma. Then you are going to have your retinoblastoma. All these things are going to be von Hippel-Lindau syndrome. Clear up. So adula onnu vandu you also have your clear cell carcinoma, clear cell cancer. Okay, of stone. Now tell me, clear cell carcinoma, where it occurs? Proximal convoluted tubule இருக்கு, loop of Henle இருக்கு, distal convoluted tubule இருக்கு, collecting duct இருக்கு. எந்த இடத்துல வந்து உங்களுக்கு clear cell cancer வரும்? Remember, usual site of origin of renal cell cancer அப்படின்னு எக்ஸாம்ல கேட்டாலோ இல்ல clear cell cancerன்னு எக்ஸாம்ல ஸ்பெசிஃபைடா கேட்டாலோ answer is going to be proximal convoluted tubule. Because renal cell cancer most common is clear cell. அதனால renal cell carcinoma எங்கேருந்து ஒரிஜின் ஆகுதுன்னு கேட்டாலும் answer is proximal convoluted tubule. Clear cell carcinoma எங்கேருந்து ஒரிஜினேட் ஆகுதுன்னு கேட்டாலும் proximal convoluted tubule. Next is going to be your papillary carcinoma. So when I'm going to tell papillary carcinoma, remember it is going to be more common in distal convoluted tubule more than proximal convoluted tubule. And it is going to have one important thing which you have in every papillary cancer. Whatever papillary cancer you take, you will see this. You will see this in the histopathology. What is that? Samoma bodies. Samoma bodies in papillary carcinoma of thyroid, papillary carcinoma of kidney. எல்லா இடத்துலையும் நீங்க பார்க்கிறது வந்து இந்த சமோமா பாடிஸ். சமோமா பாடிஸ் மட்டும் எல்லா இடத்துலையும் பார்ப்பீங்க. And இது மோஸ்ட்லி எங்க வரும்னா லாங் டேர்ம் டயாலிசிஸ். லாங் டேர்ம் டயாலிசிஸ்ல மோஸ்ட் காமனா வரும். இயர் என்ன மியூட்டேஷன் ஆகுதுன்னா c-met gene mutation. Okay, next third one, chromophobe type. Chromophobe type it is going to be tan brown color. Tan brown color. Okay, they are going to be, or I can call it as a mahogany color. Mahogany color, I think we have already discussed about this. And then you will have a plant-like cells. Plant-like cells. So what happens in this? What is the pathogenesis? If you're going to see, there is a multiple loss of, okay, there is a multiple loss of chromosome 1, 2, 6, 10, 13, 17, 21. I call this as hypodiploidy. Okay, va? So, and how will my patient will be diagnosed? Patient will have a central stellate scar. Central stellate scar. And can you tell me, your oncocytoma is going to have one syndrome we saw, which is also seen in chromophobe, where you also see chromophobe type of RCC. Burdock-Dubé syndrome. Okay, now tell me from where this is going to get originated. So, previous papillary is going to be from your distal convoluted tubule. This is from proximal convoluted tubule. From where you will get this chromophobe. Chromophobe originates from intercalated cells of collecting duct. And one important point to differentiate between oncocytoma and your chromophobe type of RCC, I told you before, that is going to be your cytokeratin positive. Cytokeratin positive. Now you recollect? Yes. Now coming to the next one, collecting duct. Collecting duct of Bellini. Collecting duct of Bellini. It is going to be from collecting duct. It is going to have a worst prognosis. Worst prognosis. So why there is a worst prognosis? Because of the deletion of 1q gene. There is going to be a collecting duct carcinoma. This will be having a worse prognosis. Next is going to be your XP11 translocation. And finally, you have a most common renal cell carcinoma occurring in sickle cell anemia. Now question comes, what is the most common cause of renal cell carcinoma and sickle cell anemia? It is medullary carcinoma. Medullary carcinoma. So what is medullary carcinoma? So it is going to be occurring in the distal nephron. It is going to occur in the distal nephron. Now, can you recollect and tell me what are the cancers where you saw it as a radio-resistant tumor? Radio-resistant tumor. Radio-resistant tumor. List of tumors which are radio-resistant. The question is very simple. What are the tumors that are going to be radio-resistant? Write it down. Number 1, melanoma. Melanoma is radio-resistant. Number 2, you have your pancreatic carcinoma. Pancreatic carcinoma is radio-resistant. Then you're going to have third one, hepatic carcinoma. Hepatic cancer is a radio-resistant. And finally, fourth one is renal cell carcinoma. There are a lot of things, but at least remember these four. These four are the renal-resistant, radio-resistant tumors. And in chromophobe renal cell carcinoma, how will be the histopathology? Histopathology, you're going to find a resin-like nucleus. So resin-like nucleus. Clear? So now coming to the presentation. How you will have a renal cell carcinoma patient coming to you. Renal cell carcinoma patient, they may not be incidental finding. Okay. So they can have 15% of patient will have symptoms. See, now 15% of patient is asymptomatic. 15% of the patient will have the triad. What is the triad? What is the clinical feature? You're going to have a hematuria. So patient will have a hematuria. Patient will have a mass. The patient will have a pain. So this is a triad. This occurs in 15% of the patient. And the most common is hematuria. But sometimes what happens, there won't be any symptoms at all. In the triad line irukadu, but there will be atypical presentation. Atypical presentation என்னன்னா உன்னோட renal cell carcinoma, it is going to go forward. It is going to develop without the knowing of patient. பேஷண்ட்டுக்கு தெரியல அவங்ககிட்ட ஒரு கேன்சர் டெவலப் ஆயிட்டு இருக்குன்ட்டு. ஆனா எப்ப தெரிய ஆரம்பிக்குது, அவன் அந்த renal cell mass metastasis ஆகி it is going to go to the lungs. Lungs la pona, how will be the features? You're going to get a cannon ball metastasis is going to occur. It can occur in the renal cell cancer can actually go left-sided specifically. They can actually go for the left gonadal vein. What happens is, now you are going to have a renal cell cancer in the left side. So when the left side, when you're going to have a renal cell cancer, the size of your kidney is going to grow, right? When the size of the kidney is going to grow, what happens? It is going to drag the left gonadal vein into renal vein. So you know that left gonadal vein, renal vein oda join agulla. And the edathila, it is going to get dragging, and that results in varicocele. Very important. Tomorrow we are going to discuss testicular tumors. So testicular tumors முடிச்சோனா hydrocele varicocele பார்ப்போம். ஓகேவா? next 2 daysல நம்ம testicular tumors varicocele and then hydrocele இதெல்லாம் டாபிக்குமே நம்ம டிஸ்கஸ் பண்ண போறோம். ஓகேவா? So this is going to occur. Now it can spread along the renal vein. It can spread along the IVC. Okay, so but remember, when it spreads to the renal vein or to the IVC, when it is going to spread to renal vein or IVC, this is not considered as metastasis. Not considered as metastasis. Metastasis na enga pogum, pulmonary ku pogum, bone ku pogum. Bone la you're going to have a pulsatile bony metastasis. Pulsatile bony metastasis. And another one important and very frequently favorite topic of examiners is to ask you about the paraneoplastic syndrome associated with your renal cell cancer. Paraneoplastic syndrome associated with renal cell cancer. What is paraneoplastic syndrome? What is paraneoplastic syndrome? Can you tell me? And the organ layo, if for example, there is going to be a Cushing syndrome. But Cushing syndrome காரணம் அதோட ப்ராப்ளம் இல்ல. கேலக்டோரியா வருது, ஹைப்பர் டென்ஷன் வருது, ஸோ ஹைப்பர் கால்சினிமியா வருது. இதெல்லாம் ஹைப்பர் கால்சிமியா ஏன் வருது? பாராதைராய்டில் ஏதாவது ப்ராப்ளம் இருக்கா? இல்ல. பட் here what happens is you are going to have a paraneoplastic where there is going to be a cancer in one area that is going to influence the production of hormones in the other area. Okay, endocrine. Paraneoplastic can be divided into endocrine and it can be divided into non-endocrine condition. Endocrineல நிறைய கொடுத்திருப்பான் டெக்ஸ்ட் புக்ல, எல்லாத்தையும் படிக்கிறதா தான் உங்க இஷ்டம். பட் மறக்க கூடாது வந்து ஹைப்பர் கால்சிமியா. ஓகேவா? And then you should never forget increase in the hypertension. Okay, increase in the blood pressure. And polycythemia. ஏன் வருது? சிம்பிள் கான்செப்ட். பாலிசைத்தீமியா ஏன் வருது? எரித்ரோபாய்டின் லெவல் அதிகமாகுது, அதனால பாலிசைத்தீமியா வருது. Okay, and there can be non-metastatic hepatic dysfunction. So there can be non-metastatic hepatic dysfunction. What is this non-metastatic hepatic dysfunction? Anyone? It is going to be Stauffer syndrome. You call it as Stauffer syndrome. What do you call it as? You call it as Stauffer syndrome. Clear? So this is going to be called as Stauffer syndrome. Okay, and Cushing syndrome. 5 point na vachkonga podum. Cushing syndrome. Okay, next. So idu mudichachu. Next, non-endocrine causes. When I'm going to ask about non-endocrine causes, amyloidosis. You have anemia, neuropathies, vasculopathy, nephropathy. You're going to have coagulopathy All these pathis will be there. And what is going to be a differential diagnosis? What is going to be a diagnosis? How do you do a diagnosis here? Investigation of choices, CECT, and for staging, you're going to do a PET scan. You're going to do a PET CT. Okay, now renal cell carcinoma imaging, you have to see always it arises from the poles. So always engage the arise ago. Here it arises from your poles. Okay, next coming to the staging. So staging alone, just to always see your latest thing which is given in your textbook. So I'll tell you, but just check it out. If it is a new one, follow this. Otherwise, just to stick on with the textbook. Okay, so you're going to have staging T0, T1. So T1 is going to be further divided into T1A, T1B. Then you're going to have T2, T3. T3, you're going to have T3A, then T3B, T3C, T3C, and then you're going to have T4. How to remember this? So your book has many different things, right? So they give you a big classification. Yeah, so there is something keywords which you have to understand. So T0 no tumor T1 when it is less than 7 centimeter. Okay, T1 less than 7 centimeter. Appa T1A, T1B less than 4 centimeters T1A, more than 4 centimeters T1B. Okay, less than 4 centimeter, it's going to be T1A. If it is going to be more than 4 centimeter, it is going to be T1B. Clear? Next, T2 na. T2 na, when it is going to be more than or equal to 7 centimeter, but remember, this is limited to kidney. So, ipada the term important. Limited to kidney. What is T3? T3 na, it is going to invade what all things? It is going to invade major veins. It is going to invade major vein. It is going to involve perinephric tissues. Perinephric tissues. If it is going to invade perinephric tissues, or it is going to involve some other thing, but it is not beyond gerontospacia, not beyond gerontospacia, not beyond gerontospacia, gerontospacia. So that is the important thing. Now you have T3A, T3B, T3C, T3A na renal vein involvement T3A, T3B na when there is going to be infradiaphragmatic IVC involvement, and T3C is supradiaphragmatic IVC involvement, Now coming to the T4, what is T4 guys? T4 now when it invades gerontospacia, when it is going to invade gerontospacia, or if it is going to invade the ipsilateral adrenal gland, then I am going to call it as a T4. Now, I am going to manage this patient. How I am going to really manage this patient? See, I am going to see T staging, N staging, M staging. Okay, TNM classification pantom. Okay, TNM classification pannappa, namak enna therinjirukom? So, whether it is a solitary tumor or whether it is going to be a complete tumor. So, main surgery, surgery is the main line of treatment. You can also go for a chemotherapy or radiotherapy. So, how do you select your surgery? If you are going to have your less than 7 centimeter, is going to be T1 or more than 7 centimeter. If it is less than 7 centimeter, go for partial nephrectomy. Okay, or if it is more than 7 centimeter, you have to go for more than 7 centimeter, you have to go for radical nephrectomy. Okay, and remember, so the partial nephrectomy indications number one, when there is T1 tumor, or when they are going to be restricted to poles, or when there is a bilateral renal cell carcinoma. Bilateral renal cell carcinoma, you go for partial nephrectomy. And finally, RCC in a solitary functioning kidney. Solitary functioning kidney, same way. So, kidney function, so we are going to do. Okay, this is all about your partial nephrectomy. So, where are you indicating relatively in hydronephrosis, in stones? And now, you are going to know all these things, right? So now, if you are going to have a radical nephrectomy, okay, so if partial 7 centimeter mela portion, I told you, you have to perform radical nephrectomy, or you can go for a total nephrectomy. So now you have to understand what is okay, radical nephrectomy, what is total nephrectomy, etc. So especially solitary functioning kidney irukku. Ana unakku T1 stage illa. T1 stage ku mela, but solitary functioning kidney. What you will do? You go for a partial nephrectomy, that is sure. Along with that, you do a pulmonary lobectomy because lung metastasis ஆயிருக்கும். Pulmonary lobectomy is going to do because there is going to be a pulmonary metastasis. Okay, so illana you can go for a total nephrectomy also. So you can go for metastasis remove pannu and you will give a immunomodulator drugs. So now what is a radical nephrectomy? Radical nephrectomy, now I'm not going to write, just listen carefully. Early ligation of your renal artery and vein to prevent the tumor spread. Then you're going to remove the kidney with primary dissection external to Gerota's fascia. Then complete regional lymphadenopathy from crux of diaphragm to aortic bifurcation. When will you do lymph node dissection? When will you do lymphadenopathy dissection? Because you're going to do when there is going to be enlargement of lymph node. When the tumor size is more than 10 centimeter, when the grade of your nucleus is going to be more than 3, presence of any necrosis, tumor thrombus, or extrarenal tumor extension, then you are going to perform this lymphadenopathy. Okay, and you have to understand one more thing. I wanted to tell you, but I'll tell this at the end, not now. Okay, so what I want to add, I'll tell at the end. But now you have to understand that when there is a metastasis, I told you how do you suspect a metastasis? How do you suspect a metastasis? By performing CECT, okay, PET scan, PET CT. And how will you suspect a renal vein invasion? Renal vein invasion எப்படி suspect பண்ணுவீங்க? Renal vein invasion இருந்ததுன்னா அதை சஸ்பெக்ட் பண்ணீங்கன்னா you have to go for a duplex scan. Duplex scan la lesion is there in the renal vein. Then you are going to perform a MR venography. MR venography is going to be performed. This is a very, very important thing. And I told you that it is going to be going to the bone, isn't it? So there is going to be a metastasis to the bone. What type of bone lesion you will get? You will get a osteolytic lesion. Osteolytic lesion. Okay, osteolytic lesion. Okay, so what is everolimus? So I told you here, right? Everolimus previously. Can you tell me what is this everolimus? Can you tell me what is this everolimus which you are going to give? Everolimus. It is a mTOR inhibitor. Similarly, in renal cell cancer also, you have some drug. What is that drug? So what is that drug you're going to give? So in stage 4, you're going to give either mTOR inhibitor, okay, or you can go for tyrosine kinase inhibitor. So what is tyrosine kinase? Sorafenib, sunitinib. All these are going to be tyrosine kinase inhibitor. So lung la enna lesion irukkum sonna cannonball metastasis. So kidney plus Gerota's fascia. Okay, if partial nephrectomy is contraindicated, you're going to go for radical nephrectomy. In radical nephrectomy, you're going to remove kidney. You're going to remove Gerota's fascia. You're going to remove ureter till the renal. Okay, and then what you're going to do? Then you're going to do a removal of plus or minus ipsilateral adrenal gland. And then para-aortic lymph node. Okay, cryoablation can also be done in the tumors of T1A type. Okay, what is the principle of cryoablation technique? It works on the principle of rapid freezing and gradual thawing. Okay, or ice ball ablate your margin, which is going to lie in 3 to 5 millimeter of your ice ball. Indication T1A. You have to remember that. Okay, so this I am just taking today, and tomorrow, subsequently, in the next class, we will see Wilms tumor and neuroblastoma because that is very long. I don't want to continue today itself. So instead, tomorrow, what we will do, we will talk about this two things, Wilms tumor and neuroblastoma. And meanwhile, I will upload the new video of your updated video of your yesterday's topic, urinary bladder and ureter. So that time you can also go through that and add on points. You can have it in a 2x or 3x and you can just see what are the points I have added. But promise that I will add some more important points because which I myself understood today. So I just wanted to tell you also so that it will be easy for you while you are reading your textbook. So very thank you. And very special thing is, right, the video is actually seen by the surgery faculty himself and he is telling me to add some point. So that looks really nice because transferring the knowledge to juniors or helping them is something that many people are not finding it. So I'm very grateful to find such a people and they are guiding you guys also indirectly. So thankful to them. So let's see tomorrow with the next topic. What I told you, what is the topic tomorrow we are going to see? What the topic you're going to see? You're going to see Wilms tumor. Wilms tumor. We will see Wilms tumor tomorrow, and we will also see Wilms tumor and nephroblastoma. Okay, difference between your Wilms tumor and nephroblastoma. Okay, then we will see neuroblastoma. Then I will also see neuroblastoma. So the other topic called as neuroblastoma. Let's compare and let's discuss it tomorrow. Subsequently, we will also discuss about the approach to testicular mass. Approach to testicular mass. So which will be discussed in the subsequent days. And you all know that breast carcinoma clinical case presentation is coming on this week, Sunday. That's very important. And you have a very senior faculty from HOD of Kanyakumari Medical College. And I think the grade of questions that he is going to ask you all or ask the presenter indirectly to you, those questions will be the standard questions that are asked in your practical. So the session will be going around 1 hour or 1.5 hours. But if you're going to listen to that, if you're going to ask any questions through that forum, sir will be ready to answer to you all. Subsequently, we will also have a discussion on thyroid cancer. So this week we have thyroid, then next week we have breast cancer, and subsequently we will try to add on all the important cases that are kept in your university exam. Repeatedly, we will have sessions, not just one session. So today we are seeing one thyroid case. Next month we will see another thyroid case. So you guys also come forward and present the case in our channel, so that if you are presenting, it will be a practice for you all, and it will be helpful for other people also. This way, it will be helpful for you as well as the other people. Okay, so thank you so much for watching. So tomorrow, let's discuss with this new topic, and I will also upload by tomorrow evening the other one, that is going to be your urinary bladder and urethra injuries. Okay, that will be very interesting. I promise you again. So that will be a wholesome topic. There won't be any addition required apart from the video you're going to watch from that. Okay, so let's see you all tomorrow.